Hello guys, welcome to Ankit Chandra. Today I'll tell you how to read X-rays in ENT and how to prepare for your ENT exams. So first, you guys should know how to comment on X-ray. First, you have to tell whether it is plain or contrast X-ray. You have to tell which region is visible, like whether it is head or neck, or is it nose with paranasal sinuses. You have to tell what view is it. You have to tell about important anatomical landmarks which are visible. Then you have to look for pathological finding which is visible, and you tell your diagnosis. Just be careful in your diagnosis to check whether it is right side or left side. Just read the label in the X-ray and then only tell it is right sided pathology or a left sided pathology. So just let me tell you what would be the outline for this video. First, we would be looking nasal bone X-rays, which would be mostly lateral view. Then we'd be looking paranasal sinus X-rays and what are the various views to look at paranasal sinuses. Then we will be looking at mastoid and temporal X-rays and different views. Then we'd be looking at head and neck X-rays. Mostly they will be all of lateral views. And in the end, we'd be looking at some contrast X-rays, which would be of esophagus. So for the nasal bone X-ray, you must know mostly we see right and left lateral views. And there are other views also like occlusal view or Waters view. Just in nasal bone X-ray, I want to tell you one point that here you can see some groove. Some groove is there. Never confuse this groove for any nasal bone fracture because these grooves are normal. These grooves are made by ethmoidal nerves and vessels. This X-ray is of nasal bone fracture. As we know, the anterior 2/3 part of the nose is of cartilaginous part and the posterior 1/3 is of bony part, and here is the fracture. It is most common fracture of facial bone. So moving on to our next level where we will be looking X-rays for paranasal sinuses. You guys must know what basic anatomy of paranasal sinuses, what are the different sinuses and where they are located. There are different views for it: Waters view, Caldwell's view, submental vertex view, lateral view, and right and left oblique view. So we'll see all of them one by one. So let's start. Most commonly you guys would have heard about it called Waters view. Waters view is generally for nose and paranasal sinuses. What is water view? Waters view is occipitomental. You can remember it by a trick. Water flows from Shivji's head like river Ganga flowing from Shivji's head. It's Om. So Om is occipitomental Waters view. It's just a trick. If you are comfortable with it, you can use, or else it's fine. What happens is patient's nose and the chin touches the X-ray film, and the direction of the X-rays are from posterior to anterior. So it's a PA view. Radiological beams are horizontal. It is the best view to visualize maxillary sinus. Generally, examiner will ask you questions regarding maxillary sinus. So the volume of maxillary sinus is around 15 ml and maxillary sinus appear at birth. One important point which you have to remember in Waters view is like you can never see posterior ethmoidal sinus in Waters view. To see posterior ethmoidal sinus, you have to take right or left oblique view. You can see sphenoid sinus. You have to just tell the patient to open his mouth while his X-ray being done. So through his mouth, here we can see the sphenoid sinus. Most of the time they will show you a X-ray with the unilateral maxillary sinus opacity. So what are the differential diagnoses for unilateral maxillary sinus opacity is sinusitis, antral polyp, malignancy, dental cyst, dentogenous cyst. What is the difference between dental and dentogenous cyst is dental cyst is an infection or from an erupted tooth it is. Dentogenous cyst is because of unerupted tooth. There could be foreign body or there could be bleeding into the sinus when there is an orbit fracture. When there is fracture of floor of orbit, then the orbital fat can herniate into maxillary sinus, which may look like teardrop sign. So how the maxillary sinusitis will look? In the maxillary sinusitis, you can see air and fluid level. You can see there is a convex floor. The line which is dividing air and fluid, it is convex in shape. So how do we differentiate acute and chronic sinusitis? Just remember that acute sinusitis will have less air content. Like you can see here, the right side is acute and left side is chronic, so you can compare very easily. The volume of gas looks black in the X-ray, so the volume of gas is less. The volume of fluid or the secretions are more in acute sinusitis, while in the chronic you will see in the left side here you can see the gas is more and the fluid is less. Just remember this. This is how you differentiate between acute and chronic sinusitis. So here you can see is another X-ray. Here you can see bilateral maxillary opacity. So mostly the diagnosis is bilateral maxillary sinusitis. So if there is maxillary sinusitis with frontal sinus is also, you can see some opacity, and here in ethmoidal sinus also you can see some opacity. So we can call multiple sinuses are involved, we can call it as pansinusitis. The next differential diagnosis what we will discuss is antro-conal polyp. How it looks, it same look like sinusitis. The only difference is the air and the fluid. Here it's not fluid, it's a mass. The line which is separating them is convex in shape. It's convex in case of polyp and it's concave in sinusitis because it's a fluid there in sinusitis, and here it's a mass. There is a opacity in the left nostril and there is a opacity in the left maxillary sinus. Diagnosis is left antero-conal polyp. So next is maxillary carcinoma. It would be a opacity, could be unilateral or bilateral. It is with bony destruction of maxillary wall. Here you can see the natural anatomy of the maxillary sinus is disturbed. There is bony erosions. As I told, dentistry research, here you can see here is the opacity in the right maxillary sinus. It's due to the unerupted tooth. So the next view which we will read is Cadwell view. In this view, the nose and the forehead of the patient touches the X-ray film, and X-ray beams are from posterior to anterior. Cadwell's view is also known as occipitofrontal view. So the Cadwell view, it is best to see frontal sinus, but here we can also see ethmoidal sinus, maxillary sinus. We can see frontal process of zygoma, we can see superior margin of orbit, lamina papyraica, and the frontal sinus is always asymmetrical. Examiner may trick you. He will say, oh look, the left side of sinus is bigger than right. So is it some pathology there? No, it's not pathology. It's the left frontal sinus is bigger than the right one. And frontal sinus is generally seen radiologically after 6 years. If there is opacity in frontal sinus, mostly it's frontal sinusitis. If there is a loss of hostrations, there will be hostrations in frontal sinus, means like projections in the upper wall of frontal sinus. If those are lost, then you can say as chronic frontal sinusitis. So if there is unilateral frontal sinus opacity, what could be the differential diagnosis? The most common differential diagnosis could be osteoma. Second could be fungal sinusitis. Fungal sinusitis generally would be a fungal ball. This is most commonly seen as maxillary sinus. It can occur in frontal sinus also, associated with bone destruction. Third could be foreign body. Remember not to answer as mucocele because it is very difficult to diagnose mucocele on X-ray. In frontal sinus, as I told, the most common pathology which you can see is osteoma, which is common in frontal and ethmoidal sinus. How the osteoma will look? Osteoma will be well circumcised. It will be round. Generally, it will be less than 2 cm in size. The next which we look is bucket handle view. In bucket handle view, we send the X-ray beams below the chin. It's called submental vertex view. It is best to see zygomatic arches and sphenoidal sinuses. In submental vertex view, the best sinus what we see is the sphenoid sinus. Then we can see posterior or ethmoidal sinus and the maxillary sinus. So the zygomatic arch fracture you see best in submental vertex, but you see zygoma fracture best in Waters view. Zygoma fracture is also called as tripod fracture. Why it is called as tripod fracture? Because 3 fractures which are occurring: zygomatico-frontal fracture, zygomatico-temporal fracture, and infraorbital fracture. So next view for paranasal sinuses is the lateral view. Lateral view is best to see the anterior and posterior extent of sphenoid sinus. Here you can see this is the sphenoid sinus. We can see the anterior and posterior extent. And just above is the sella turcica. Most of the examiners may ask you locate the sella turcica in the X-ray. Why they tell you to do so is because sella turcica is very important structure, because in sella turcica we have a pituitary. To do some surgery of pituitary gland, there is something called endoscopic transsphenoid surgery. In that we go from the nose directly to the sphenoid sinus, then we break the sella turcica and do the pituitary surgeries for some adenomas. There's lot of ways to see mastoid. There are lot of views. In this video, we will just see Law's view and Schuller's view. So the Law's view is the lateral oblique view of mastoid. In this, rays are directed at the angle of 15 degree. The only problem with Law's view is like the key areas of mastoids are not seen. What are the key areas of mastoid? Attic, additus and antrum. These are not properly seen in Law's view. Therefore, we came up with Schuller's view. Schuller's view is very popular and most commonly used. In this, instead of 15 degree which we are using in Law's view, we are using a 30 degree cephalocaudal X-ray beam. What happens with the 30 degree is this angulation provide to separate right and left mastoid. This angulation also displaces the arcuate eminence of the petrous bone downward, showing the key area. As I told, the key areas are very nicely visible. You can see the antrum, the upper part of the attic area. Here you can see mastoid cells in a honeycomb appearance. So most commonly we will use Schuller's view to see the pneumatization, to diagnose for mastoiditis, to look for sinus plate. Towner's view we will use for acoustic neuroma and apical petrositis. So here is the first X-ray. It is mastoiditis. Here I can see clouding of mastoid air cells. As I told, the normal mastoid hair cell look like honeycomb appearance. Here you can not appreciate air cell. Here you can see only the clouding, like diffuse haziness. So it's mastoiditis. So the next common viva what the examiners they ask is if there is a large mastoid cavity, like here you can see. So what are your differential diagnosis? What all you can think of? So first you can think of cholesteatoma, or you can think this person have undergone mastoidectomy and then post-op we are taking this X-ray, or it could be histiocytosis, or it is normally like some patient may have a large antrum cavity, or it could be eosinophilic granuloma. Eosinophilic granuloma will have hairline appearance, or else it could be TB mastoiditis. So here we will learn how to differentiate between cholesteatoma or post-op mastoidectomy X-ray. Here in cholesteatoma you will see margins are smooth. It looks like cotton wool appearance. There will be bony erosion, which is a key feature of cholesteatoma, and there will be sclerosis of the mastoid air cell. Where in post-mastoidectomy X-ray we will see irregular margins because there will be osteogenesis. It will be homogeneous in appearance. There will be no sclerosis. Most of the time examiners love to ask what is Sino Dural angle and where is it. So first, how you have to find the Sino Dural angle is, you have to first locate the temporomandible joint. Here you can see this is the mandible, this is the TM joint. You will find this is the dural plate, and here is the sinus. So this angle between the dural plate and the sinus is called sino-dural angle. This sino-dural angle, it is very important landmark for mastoid surgery. It is used for prognosis. If it is ruptured during the surgery, it means the prognosis is very bad. This sino-dural angle is generally acute in case of primary sclerosis and obtuse in case of secondary sclerosis like COSM. So the next what examiner love to ask is what is MacEwen triangle and where is it? MacEwen triangle is a triangle between the temporal line, posterior superior segment of external auditory canal, and a tangent drawn through the posterior border of external auditory canal. Here you will find MacEwen triangle. The importance of this is mastoid antrum lies approx 12 to 15 millimeter deep to it, and also it contains the spine of Henle. Most of the time examiner will ask you where is the MacEwen triangle. So here you can draw. Here you will find MacEwen triangle. Just for the viva purpose, examiner may also ask you what is Trotman's triangle. Trotman's triangle is between superior petrosal sinus, sigmoid sinus and solid angle. They may ask you what is solid angle. Solid angle is an angle where all the three semicircular canals will meet. Trotman's triangle is a pathway to posterior cranial fossa from the mastoid cavity. Next, moving on to head and neck X-ray, you must know where are the normal spaces in head and neck. Just in front of the vertebra is prevertebral space. Just in front of prevertebral space is retropharyngeal space. Normally retropharyngeal space is around 7 mm at C2 level and 22 mm at C6 level. So in the next level we'll be seeing head and neck X-rays. Mostly they will be of lateral views, and lateral view is the most useful view to see head and neck structures. In head and neck X-ray Just remember this key point. Whenever you want to locate a particular spine, just always count the spine from the bottom, because if you start counting from above C1, C2, there will be some mistake or error you will make. Just to tell you a common anatomy, that trachea is in front, esophagus is behind the trachea. This opacity is hyoid. Pharynx extend from the base of skull till C6 level. Nasopharynx is from base of skull till C1. Oropharynx is from C2 till C3. From C4 till C6, where is your cricoid, is the hypopharynx. So now let's move on. The first X-ray is retropharyngeal abscess. How we are able to say is, when we say increased prevertebral space, when it is more than 2/3 of the AP diameter, then we can call it as retropharyngeal abscess. We can measure from the scale. As I told you, if the distance is more than 7 mm at C2 or more than 22 mm at C6 in adults, then we can call it as retropharyngeal abscess. I would like to tell you guys that you cannot differentiate between retropharyngeal abscess and prevertebral abscess. They both will look same in the X-ray. So the basic question which they would be asking you in viva is, what are the causes for retropharyngeal abscess? The most common cause of acute retropharyngeal abscess in children is because of tonsils or adenoid are infected, or in adults is because of some surgical trauma, like while doing endoscopy. Chronic retropharyngeal abscess could be there because of infected lymph node of the retropharyngeal space. The most common cause for prevertebral abscess is tuberculosis spine, and this can also result in infected lymph nodes of retropharyngeal space. Retropharyngeal space is divided into right and left space of gillette by a fibrous raphe. The retropharyngeal space is situated behind the pharynx, and it extends from the base of skull to the bifurcation of trachea. Most of the time examiner may ask you, like, how can you differentiate between prevertebral abscess and retropharyngeal abscess? The key point is, the prevertebral space is continuous from your base of skull till your coccyx, and if there is abscess, it will be diffuse, while retropharyngeal space is divided into right and left space of gillette. So retropharyngeal abscess will be toward one side. The parapharyngeal space is situated on the side of pharynx, which contains like your carotid vessel, jugular veins, and last 4 cranial nerves and sympathetic chain. Most of the question what the examiner may ask you, how do you drain a retropharyngeal abscess? Retropharyngeal abscess is generally drained by making an incision on the posterior surface of sternomastoid muscle. And while for the parapharyngeal abscess, we make an incision 2 or 3 cm below the angle which is on the anterior surface of sternocleidomastoid muscle. So here you can see there is increased prevertebral space, so it's a retropharyngeal abscess with there is a deformity at the spine too. There is erosion of cervical vertebrae, reduced intervertebral space, so there could be a retropharyngeal abscess due to pot spine. Here you can see a retropharyngeal abscess with a foreign body. Here is the foreign body. Here you can see some air. So it means it's an abscess. Wherever you see a air fluid level, always suspect of an abscess, because when there is an abscess, there will be bacteria will be producing gas. At the junction of roof and the posterior wall of nasopharynx, you will find a mass. Mostly that would be adenoids. Adenoids are although present at birth, but they are generally invisible till 3rd to 6th month. Newborns won't have visible adenoids, but they will have adenoids at birth. They grow until about the age of 6, and in adults they are not visible. So what are the other masses which could be present at nasopharyngeal space? The first could be adenoid, the other could be juvenile nasopharyngeal angiofibroma, other could be nasopharyngeal carcinoma, dermoid cyst, or antro-conal polyp. Adenoids are anterior-inferiorly, antro-conal polyp are posterior-superiorly, which give crescent sign. Antro-conal polyps are differentiated from angiofibroma by the presence of column of air behind the polyp. So here are two separate X-rays. One is epiglottitis X-ray and another is croup X-ray. As we know, in epiglottitis X-ray we find the thumb sign. Here is the thumb sign. It looks like someone have kept his thumb. The epiglottis is swollen. It's an emergency condition. In this, we try to avoid give any painful stimulus to the patient. Instead, we directly rush the patient to ICU or operation theatre. and there in presence of an ENT surgeon and anesthesiologist, we try to give IV antibiotics and intubate. Here is the steeple sign. Steeple sign generally looks like this. But in X-rays, most of the time we will find only the lower bottom part, which we call as church top sign. The upper part is generally called as pencil tip sign. If we see both the shadows, then we call it as steeple sign. So the next X-ray which we will read is, it's an AP view X-ray. Here we can see a radio opaque shadow which is round. For the foreign body, you must also mention that the radio density of foreign body is equal or more than the normal radio density of a bone. Like here you can see this is the normal radio density of bone, and this is the radio opaque object which is foreign body. This is more whiter than compared to the normal bone. Most probably it could be a coin. So most of the time examiner would be asking you, can you tell where it is? Is it at esophagus or at trachea? So the point is, on AP view we can never ever confirmly say that where it is. You can just only guess that it is an esophagus, because esophagus is compressed in AP diameter. In anterior posterior diameter, it is compressed between the vertebra and the trachea, and a coin would occupy this position very easily. But to confirm, you always have to look at the lateral view. Never give your confirmed diagnosis on seeing the AP view only. You have to just say, sir, I would like to see the lateral view X-ray for this patient. Then the examiner will show you the lateral view. Here you can see that this is behind the trachea. This is the airway and it is behind it. In between the vertebra and the trachea is the esophagus. So mostly this coin is at esophagus. The most common question which examiners will ask you, what are the normal esophageal constrictors? So the first constriction is at Crico-pharngeal, which is at the level of C6. From the central incisor, the distance is 15 cm. This is the most common site where most of the foreign body will struck. So for esophageal foreign body, we generally remove it under general anesthesia using rigid endoscope and with a different size of forceps. Obviously, the size of the forceps should be longer than the rigid endoscope, because we pass the forceps through the rigid endoscope and take out the foreign body. With flexible endoscope, you can only remove the soft and small foreign body. Like in this X-ray here, you can see the foreign body. If the foreign body have passed the esophagus, most likely it will pass on through the antrum and the small intestine and large intestine, and it will be passed in the stool. But there are certain chances that it may get stuck. So in the foreign body, the most common pet questions are like, which is more dangerous, organic foreign body or inorganic? Obviously organic foreign bodies are more dangerous because they swell up in size, so it becomes very difficult to remove them. But what is the most dangerous foreign body? Button battery. Button batteries are the most dangerous foreign body, as they release chemicals and may damage local tissue and structures within 1 hour. So we have to act very fast in button battery. If this button battery is there in the ear cavity, then it can even damage the facial nerve also. In the lateral view, you can see there is a foreign body in the airway. Most of the time, the foreign bodies goes to the right main bronchus compared to the left main bronchus. Why they go more commonly at right main bronchus is because there is a lesser angle of convergence at the carina compared with the left bronchus. Or in a simple term, right bronchus is comparatively little straighter. If it is due to large food bolus, then we have to do Heimlich maneuver. We have to maintain the airway, and then under the general anesthesia using the rigid bronchoscope, we can remove the foreign body. In this, rigid bronchoscope is preferred because we can maintain the ventilation also. So next is contrast studies. Till now, whatever X-ray we saw was the non-contrast X-ray. Here we'll see the contrast X-ray. They have one advantage that we can see even small pouches or any constrictions, but there is certain contraindications, like we cannot use contrast in esophageal or any GI perforation or wherever there is any fistula in the body. Most commonly we use barium sulfate. Barium sulfate have advantage that it is inert, can be mixed with food or water. When the person take the barium sulfate, which is a contrast, with the food, then we call it as barium meal. When the barium is swallowed directly or with water, then we call it as barium swallow. If we put the barium sulfate through his rectum, that's called as barium enema. The disadvantage of barium is it acts like foreign body when it leaks outside the GI tract. So here is the first X-ray of radio contrast. In this you can see there is regular dilation of esophagus and there is a smooth stricture. This smooth structure generally we call it as rat tail appearance or bird beak appearance. So this is the hallmark feature of achalasia cardia in X-ray. So examiner may ask you what treatment you will do. We can use some drug like calcium blockers, or else we can do modified Hallis operation, a surgical procedure to treat achalasia cardia. Next is esophagus malignancy. In this, here also you will see a stricture, but it is irregular because of malignancy, which we call as shouldering effect, and it gives an appearance of apple core, as if like someone have eaten the apple and the only core is remaining. Here you can see. So here on barium swallow we see there is a stricture here which is irregular, shouldering effect is present, so mostly it would be a lower third of the esophagus, some malignancy is there. Here you can see some shelf-like projection which we call as web. It's a Crico-pharngeal web, generally seen as Plummer-Vinson syndrome. Plummer-Vinson syndrome patient will have angular stomatitis, iron deficiency anemia. Around 10% of the patient will develop post-cricoid carcinoma. This X-ray, this is also barium swallow. Here you can see a nutcracker esophagus. Here there is a sustained peristaltic contraction. So guys, these days, as I told, I am updating my question banks. Already I have updated second edition of pharmacology. For ENT, the second edition would be published by tomorrow evening. So whosoever are interested, they can buy, and then you can use these ebooks in your mobile or in your laptop or in your tablet by using Kindle app in your mobile. So it's very easy. So wherever you go, you can read those ebooks in your mobile. Whosoever have already bought my question banks, they can update it by going to Amazon website, click on manage content and device. From here you can regularly update my questions bank. So thank you guys for watching this videos. Subscribe to my channel, follow me on Facebook. See you guys in my next video. Tata, bye bye, all the best.